about and focus on is stem cells. And that's where we get into restoring neural pathways and neuroregeneration. So I'm going to cover a little bit of neuroprotection. I'm going to talk a bit about some non-stem cell treatments that are being investigated right now for restoring or regenerating neural pathways. And so I'll talk about these words moving forward. So I mentioned this, some of the big studies I've listed here: steroids, macrophages, GM1 or Ganglioside GM1, Sygen, and Proneuron were the drug companies associated with these studies. Cooling the body down to decrease the amount of inflammation has been studied a few different ways. Riluzole is a drug that I'll talk about, and then, like I said, I'll get into neuroregeneration a bit. So steroids, have you guys heard about steroid use after spinal cord injury, getting nodded to the head? Has anybody heard that, or did anyone have that after they were injured? So looks like maybe a third of the people in the room had steroids. So the idea is that it would decrease, like most steroids do, they decrease inflammation associated with injury, sometimes associated with arthritis or other inflammatory disease processes. I think Carl's trying to get in. Okay. There's been several studies, several big studies looking at steroids, and this remains a controversial topic. I'll just start with that. Currently at our center, it's not protocol to give people steroids after spinal cord injury because of the increased rate of complications. These national acute spinal cord injury studies, 1, 2, and 3, were all large studies with over 100 subjects, 100 patients with spinal cord injury in those studies. The first study had very high dose of a drug called Epidural. They all used that drug, but this one used it in very high doses. And the drug was given in such high doses that, in fact, more people died that got it that didn't get it. So that was obviously seems a bad thing. And the next two studies, much lower doses of steroids were given. And it was unclear if there was really an improvement neurologically down the road in the patients that got steroids versus those that did not. The second and third, they kind of went back through all the data and tried to find anything that might have been relevant. And they found that if you were younger and you got steroids within 8 hours of injury and you had some sparing of sensation or strength below your neurological level of spinal cord injury, that you had a better chance of improving than if you didn't get the steroids. So because of that, some surgeons are still, and some trauma doctors who are still the first ones on the scene when someone comes in with spinal cord injury, are giving steroids if it's within 8 hours of injury. It's pretty rare that Dr. McKenna or I or a rehab doctor is called that quickly after injury. So by the time we're involved, it's usually past that window. So we oftentimes do not recommend that a team go down the pathway of giving steroids, because all of the studies have shown increased rates of infections, pneumonias, sepsis, which is infection in the blood, spread to the blood. So steroids are a little tricky, and right now not universally recommended. That's not a clinical practice guideline to give steroids. Macrophages are normal inflammatory cells in the body that help decrease inflammation. So this is a pretty interesting study that was put into trial, I think late 1990s, early 2000s. And showed some potential benefit. And what they did was they took a patient's blood and they separated out these cells, these macrophage cells, and they grew them, they inoculated them to grow in quantity, and then they injected them back right around the spinal cord in the spinal cord fluid and allowed them to clean up the inflammatory debris. So they put the patient's own cells in higher quantity to fight off inflammation after injury. And they looked at the results. And what they found was a 30% conversion rate of patients who had no sparing of neurologic sensation or strength below the neurologic level. So ASIA impairment scale A injuries, so sensory and motor complete spinal cord injury. 30% conversion rate is a little bit better than just the natural course of spinal cord injury, which is about a 20% conversion rate. The phase 2 study, I believe, is still suspended, Steve. I don't know if you heard anything more about that when you were at Asia and ISCOS, but it was looked to go into a bigger study, more patients, and ran out of money and is not currently eligible or open for enrollment. Ganglioside GM1 is another neuroprotective study looking at giving somebody this drug that helps stabilize the nerve cell membranes in a way that would decrease the amount of cells that were susceptible to dying off that weren't initially damaged to the point that they wouldn't be functional. So getting back to the idea of minimizing that complicated secondary inflammatory cascade to hopefully allow for neurological protection and improved function down the road. What they found with this study, and I have the molecular structure over here, interestingly, this is really important for nerve cell membranes, and it's very similar to Campylobacter, which is a bacteria that when you're infected with it can cause diarrhea, severe diarrhea. And there's a syndrome called Guillain-Barré syndrome that you may have heard of that's a peripheral nervous system disorder, and essentially the body is trying to fight off this, and the immune system gets revved up to this molecule and accidentally starts to attack the person's own healthy nerve cell membranes because the structure is so similar. But in spinal cord injury anyway, it's not shown a significant benefit in multi-center trials. There were trends of improvement, but not clearly effective. Riluzole is a drug used in ALS, amyotrophic lateral sclerosis. You probably know it as Lou Gehrig's disease. So that's a disease of the anterior horn, the anterior part of the spinal cord. It's a neurodegenerative disorder that doesn't have a lot of good treatments, and the prognosis is generally pretty poor for patients that have ALS. This drug, though, has been FDA approved for treatment because if it started early enough, it can prolong life slightly in ALS, and it can keep patients at a higher functional state for a longer period of time for sure in a lot of the studies that have been done. So it was thought because of its mechanism, where it acts is it acts to block sodium channels. Sodium channels get opened and stay open longer after spinal cord injury, allowing more calcium actually to flow into the cells, and that leads to the cells being less stable and ultimately potentially not being functional and dying off, which obviously results in more neurologic loss and less function down the road. So this study is actually still going on, and I believe at the Spinal Cord Conference Steve just went to, they were talking about it, but they have published one of their studies, and what they did is they gave patients with acute spinal cord injury, cervical or neck injuries that had no says AS through C. So they had no significant sparing of motor function, possibly a little sparing of motor function, and 36 patients were enrolled and compared to natural course of spinal cord injury recovery. And what they found was this. This is just kind of look at the lines here. Riluzole is the top line, and the bottom line in all of these is just natural history. No drugs were given, no steroids, no other treatments were given, just standard of care, spinal stabilization, rehab, ICU management. So if you combine the ASIA A, B, and C, and again, ASIA A being complete loss of sensory and motor function below the level, B being some sparing of sensory function, C being some sparing of motor, but not a lot of motor function spared, essentially. So if you look across these groups combined, you can see that the top graph shows that there's more motor recovery if the subjects were given riluzole than if they weren't. And if you look at complete motor and sensory spinal cord injury, or the ASIA Impairment Scale A, they did better at 3 months clearly, but at 6 months, the lines were getting a little bit closer. So that benefit they had at 3 months wasn't as significant at 6 months, and actually lost statistical significance at that point. The grade B, the incomplete sensory patients, had more motor recovery at 3 months and at 6 months, but those who had some motor function really didn't do any better if they got riluzole or not. What they did find is that more of the patients that had impaired motor function, so the complete motor patients that had some sensory function, the ASIA Impairment Scale B, those patients improved to having motor function more often than they would have if they didn't get the drug. So that's kind of a big finding, right? So 100% of the patients who were sensory incomplete improved to having motor function below their level of injury, compared to only 60% of those who didn't get the drug. So that is now in a bigger study, more subjects trying to enroll throughout the country. I'm going to move on to cooling, which you guys have probably heard about. You guys know who this guy is? I don't know if you can see, there's his name there. What's that? Yeah, exactly. Injected ice and it was fine. It's basically that, yeah, chilled saline was injected. So he was a Buffalo Bills special teams player. He was trying to block on a kickoff return, and he ducked his head down, got hit, had a cervical spinal cord injury on the field. He was actually noted to have a spinal cord injury immediately, put in the ambulance, and upon getting to the hospital he went to in Buffalo, they started this experimental study, which was just open to enrollment in Miami. They were looking for people to get into this study. And he was given chilled normal saline through a central venous catheter, decreasing his core body temperature by 1 to 4 degrees Celsius, which is, you know, more like 7 to 10, 12 degrees Fahrenheit. So he was cooled down for 3 days post-injury. And then they said in their paper several additional days. So it wasn't exactly clear what they did in his case. There's been several published papers. One paper says he had no function below his level of injury and no strength. The other said that he was actually moving his legs very clearly in the ambulance and in the ER. Regardless, he had a good outcome. He was able to recover walking, I believe, both voluntary bowel and bladder function a year out from injury. Regardless of his case, that sort of got it out there in the media that maybe if we cool the core body temperature in people that have spinal cord injury, they'll do better down the road. And this is not a new technique. This is something used in a lot of other surgical interventions, including cardiovascular surgery, to help with outcomes and help with function in those organ systems and decrease rates of complication. Anyway, in terms of spinal cord injury, the study done by the Miami Project to Cure Paralysis was published in 2010. They're still trying to enroll more patients in a larger study right now, but I'll talk about the results of that study. So in this study, it was all cervical spinal cord injury patients that had no significant preservation of motor or sensory function below the level of injury. And their core body temperature was cooled down to 33 degrees Celsius for 48 hours exactly. And that was followed by a slow rewarming period. If the body's rewarmed too quickly, there's also things that can go wrong. So there were higher rates of Asia Impairment Scale conversion in this study very clearly. So if you look here, remember all the patients had Asia Impairment Scale A injuries or motor and sensory complete spinal cord injury. And of that, we'd expect about 80% of those patients, just by natural history, to remain at the A category at 1 year out from injury. What they found was that actually less than 60% stayed as A's and more than 40% changed. So that's a little bit more than twice the amount of conversion to either sensory function coming back and or motor function coming back, which is impressive. There were similar severe complications in terms of DVT or clotting in the legs or clotting that reaches the lungs, or sepsis, which is severe infection that reaches the bloodstream. But there were more urinary tract infections, pleural effusions, and anemia in the group that received cooling. There's also an interesting surgical technique that really isn't widespread use or in widespread study yet. However, it's the idea that when the surgeon goes in anyway to get down and stabilize the spine, go a little bit deeper and expose the dura, which is right here. That's the lining that sort of encases not only the spinal cord, but also the spinal fluid. And what this study did was they specially designed this catheter or this saddle, as they call it, to put in right over the dura before they close the patient up, and for 4 hours, keep them open, infuse cold saline down through this sort of system. This is the sort of illustration of what goes on. This would be the patient on their side, and through higher magnification, you can kind of visualize right here. So this would be the dura. This is them sidelined, so you can't see the spinal cord, which is running sort of this way. But this is sitting right over the lining around the spinal cord. And this cooling solution is going in and out and just sort of flowing to cool down the spinal cord. So the whole body is not cool, just the spinal cord itself. And needless to say, this study's come under a fair amount of scrutiny. There's a lot of surgeons who emailed, or not emailed, but put in letters to this journal that published this. But I do think it's sort of interesting and sort of focal treatment that could decrease the amount of systemic complications from cooling that we see elsewhere. Anyway, it was 4 hours. They did this since 1977, which is longer than I've actually been alive. but and this is actually predates the ASIA examination. So how these patients all had complete motor ASIA A impairment scale, it's pretty hard to say that because the scale wasn't even around back then. So anyway, there's some issues with that. But they did find a pretty high conversion rate. So we would expect that 80% of patients would remain at the A status, the A category. But actually 65% of patients moved on versus 20% through national history. So seems like a study worth pursuing. They didn't have a lot of severe complications. They had slightly increased rates of sepsis, GI bleed, pneumonia, and DVT. No deaths in that study. And the patients were actually given steroids, or at least half of them were given steroids. So it's there's a lot of confounding information, but something that you may have read about because it's been in a few different journals and magazines. So regeneration, I'm going to start to move through this a little bit faster so I don't eat up any of Dr. McKenna's time. But, and he's going to talk about stem cells and how they can be driven down lots of different tissue lines to regenerate ears, or regenerate neural pathways, or regenerate cartilage, or regenerate pancreatic tissue to help with diabetes. So he's going to talk more about that. But what about other regenerative ideas? So remyelination I'll talk about, neuroplasticity in terms of synaptic. Synapses are those connections between different neural tracts, between the brain and the neural tracts that go out of the spinal cord, specifically is what I'm going to talk about. And then axonal regeneration would be those tracts or those pathways sort of recovering and building their own new track down to the affected organ that has lost function, whether that be a muscle, a motor unit of a muscle, or a bladder muscle, or sensation. So this is just a very simple cartoon of how neurologic recovery can happen, and we know that it does happen in these ways through different animal and human experiments in spinal cord injured populations. So if you think about this as maybe just like the brain, or a tract that's originating in the brain going down into the spinal cord, and then think of this as maybe a muscle on the thigh, the quads. And if there's spinal cord injury that isn't terribly severe, where there's compression of a tract, it may be that just the insulation, right, the myelin around the wire is affected, but the wire is okay, the axon being the wire, the myelin being the insulation. So if the body can find a way to just heal up where that tract is lost its insulation, well then the speed of that signal can go back to being more normal, and the body can become more functional and improve. So that's one way, remyelination. We know this happens both in the peripheral nervous system, in the arms and legs, as well as in the spinal cord, and even in the brain. Collateral sprouting, or synaptic regrowth, we also know takes place after spinal cord injury. I'll show you some evidence of that. So that would be a little bit more damage, right? The wire has been affected so much that it's no longer in continuity, but a nearby pathway, a nearby nerve tract that goes maybe a similar path down into the leg may regrow. And there's also parts of the brain and the spinal cord that are latent, that are not, that we don't rely on in our day-to-day function, that are nearby and maybe not active, but could be triggered to be active and potentially grow over and take on that function that was lost by the pathway that was affected by the injury. And then just a similar idea, the tract sort of growing around the injury itself is the idea of axonal regrowth, or the wires sort of regrowing their own connections. Synaptogenesis, this was proven by Hall, Beatty, and Bresnahan, who are actually researchers in San Francisco now at UCSF. And they showed very clearly through this experiment and several other animal models that rats who, under experimental conditions, have a spinal cord injury, show signs of new connections going across the spinal cord injury. So this is a spinal cord cut in cross-section on a rat at autopsy, after it was given a spinal cord injury through a controlled sort of experiment. And through higher power, here you can see these little kind of white dots going across that lesion. There's special staining here to pick up on myelin or pathways going down through the lesion itself. So we'd expect that to not have any of those dots if there was no ability for the body to grow new connections down through the spinal cord lesion. And so here at higher power, you can see these white dots. You can see those white sort of spots going through the lesion and here. So this was sort of groundbreaking and sort of reinforcing the idea that, yes, the spinal cord can regenerate new pathways. Does this happen in humans? It does. We know that through different brain studies. We know that certain other experiments have suggested that treadmill training, really task-directed behavior, like having a therapist work with you on a standing frame, or having them start to work with you on taking a step, or start to work with you on transferring in and out of bed, or the autonomic nervous system getting more accustomed to take on positions in the sitting position from the lying position. We know that we can assist the spinal cord through this path of axonal regrowth, building new connections through intensive therapies and rehabilitation. Some newer strategies: electric stimulation, neuromuscular facilitation is a therapy approach that is used by oftentimes by our therapists. But before going down that anymore, I want to talk about how we're a little different than rats and mammals. Rats and other mammals have very small brains and big spinal cords, thick spinal cords, lots of neural information. We have huge brains and little tiny spinal cords, about the size of, a thick pen or my pinky finger at the very most. So, and then we have obviously large brains with a lot of information. So the idea of a central pattern generator is that there's this other sort of built-in bulge in the spinal cord down towards the hind limbs in quadruped mammals that are walking on all fours, right? And humans have sort of evolved to lose some of that. Have you guys seen videos of cats that are able to walk after having their spinal cord cut in experimental models? Have you seen that or seen stories about that? So the whole idea behind that is you're able to retrain a cat to walk, even though they've lost the connection from their brain down the spinal cord to their legs. There's enough information at the base of the spinal cord to take on that rhythmic, coordinated movement through different training, including treadmill training, where they would place the rats or cats' feet at the right spots and slowly not have to do it as much until the point where they can walk on their own. So that's kind of the idea here. In quadrupeds, it's clear that there's a caboose, if you will, a driver at the base of the spinal cord, whereas in humans, it's a little less clear. However, there's a new study I'm going to talk about briefly that suggests that maybe there actually is. So this is one of those cats. The cat is, the spinal cord is completely cut. It's cut up above, and you can see there's a guy in the back holding the tail up. And, it's not totally probably normal walking, but over time, the cat's able to actually walk better. Now, he's just barely holding the tail up. The cat went through 2 weeks of this sort of training on a treadmill of where to put the hind paws and giving the cat more sensory feedback so it knows where things are at through reflexic sort of mechanism at this central pattern generator, or this sort of second central nervous system director, if you will, at the base of the spinal cord. Didn't rely on the brain at all to take on walking again. So a lot of these studies, body weight supported treadmill training, which is essentially this little vest, if you can see that on there, is suspending the cat a little bit so it has to put more weight on its legs. In humans, they've done body weight supported treadmill training, lots of studies, and there's lots of equipment and devices out there to support that idea in therapy. It hasn't shown consistently, though, to be effective in humans, other than in people who have lots of neurologic pathways spared and a lot of neurologic function, strength, sensation spared after spinal cord injury. And when you compare it to just going through standing frame, parallel bar training, walking with a front wheel walker, or progressing through sort of more traditional or classic rehab approach versus getting on a treadmill with a harness that suspends the person and takes on more of the work for them in standing and walking, it hasn't shown a clear benefit. And in people who don't have any information or function below their spinal cord injury, that have loss of motor function and sensation, it hasn't shown to promote neurologic recovery. So, so that brings me to this. Have you guys come across this? I was on a flight on Southwest, and I read about this. So I'd imagine someone else has read about this. So epidural electrical stimulation. The people doing these studies are not exactly clear on why this works. I'm just going to say that for sort of to put that out there, because there are theories on why this is working, but it's not totally understood on exactly why it works. It was working very clearly in animal models enough that it got approval to go into one patient at one center in Kentucky, Fraser Rehab, through University of Louisville. So what it is the idea that you can put electric stimulator on the dura, not inside the dura where the spinal cord and the spinal fluid is, but on top of the dura, provide some low-level stimulation, and somehow unlock or modulate these pathways in the spinal cord that aren't disrupted right here by the spinal cord injury, right? They're not totally, the spinal cord isn't cut. Some of these pathways going up and down the spinal cord are affected pretty clearly. But there's nearby pathways, and the theory is that by sort of unlocking those pathways, they're able to provide neurologic continuity down through the spinal cord that allows functional recovery. And so what these studies have shown is that patients given epidural stimulation for long periods of time, these are very intensive studies, I'll talk about it briefly, were able to recover the ability to stand on their own using a frontal walker or a standing frame, but without anyone holding their legs, and even take a couple steps and even be able to move muscles in their legs with the stimulator turned on that they wouldn't have been otherwise. And even when the stimulator is turned off and they're asked to move, they can't move. If it's turned on, they can move. So I'll show you a video that actually demonstrates that. So that's the basic concept. I know it's very complicated, but basically the research is almost ahead of the basic science a little bit. We know that through the gate control theory for pain, this is a proven idea and actually been FDA approved for chronic pain management for a number of years. So these spinal stimulators, I'll show you on the next slide, the slide following this, but these spinal stimulators have been put in to give a low level of electric current around the spinal cord to create a different feedback for the brain to focus on rather than the brain just focusing on the chronic pain that the patient has. So even not in spinal cord injury, just a chronic pain population, these stimulators have been used for a number of years. So this patient that got it was 23, a T2 Asia Impairment Scale B, which means he had some sensation below his level of injury, but no motor function. And that was for 3.5 years, so he was pretty chronic. It wasn't like he just had his spinal cord injury. He went through, they required him to go through 170 of these intensive walking studies, locomotor studies with body weight supported treadmill training, just to make sure that nothing was coming back and that the study itself wouldn't be confounded by maybe natural recovery or some of the therapies they were doing in addition to standing and the walking. So he went through all of that, and then he got the surgery, got this epidural stimulator placed, and went through an additional 80 sessions over 6.5 months of epidural stimulation and therapy training. And the training sessions were intensive, 60 minutes to 2.5 hours, or 250 minutes, which is over 4 hours, right? So these were long sessions, a very intensive study. I think it was 6.5 months because they gave him 2 months to heal up after the surgery. So this is his x-ray. If you guys are familiar with this, so this is the T9 vertebrae, T10, 11, 12, L1, L2, 3, 4, 5, and the sacrum's down here. So this is the stimulator itself. And like I said, this has been done by surgeons for years to help with chronic pain management. But the same stimulator was put in. So this is placed right here. This would be the spine. The spinal cord is going down through here, bones on the back and the front of the spinal cord. And this is the conus medullaris, which is the base of the spinal cord. And if we do have that caboose or that central pattern generator, this is where it is. So the idea was to try to put the stimulator in where there's a lot of neural information. We know that in humans, most of the spinal cord just has one level per vertebrae in terms of neurologic information, both sensory and motor. But at the base of the spinal cord ends, and the cauda equina all below L1 is just a bunch of nerve roots floating in the spine. The conus itself has L1 basically through S1 information. So 5 or 6 segments crammed into one vertebral level, whereas the other level it's more one-to-one. So the spinal cord stimulator was, the epidural stimulator was placed there. And after he went through all this training, remember he has no strength in his legs before this study. You can tell that he's requiring some positioning, some help to get in there. He was able to stand for up to 4.25 minutes after 6.5 months of training. So he is a T2, so that would mean that he doesn't have abdominal muscles, he doesn't have paraspinal muscles really to help him stay straight. So he's requiring the stimulator. The stimulator's on right now. You can see there's some shaking and some fatigue of those muscles that are trying to fire to keep him up. So he's able to make it up to 4.25 or close to 4.5 minutes. Yeah, let's go next. So then, did he recover function? Could he move? So this is with the stimulator turned on. You can't hear the volume, but she's asking him to move. And you can see he's able to flex his knee up. 4. Ask him to move it up again, and he's able to move it up. Pretty much on command, he's able to move it up. See that I'm going over my time. And he's able to move his toe up. So he's able to do that pretty clearly on command. And there's another video that basically shows them trying to do it with the stimulators turned off, and right when they turn it off, you cannot move the leg again. So they did a bigger study. They enrolled 3 more people, so the total of 4. The first subject is this subject. They were all over 2 years out from injury. They all had either cervical or thoracic spinal cord injuries that were complete motor, so no C's or D's, no motor function, significant motor function below the level of injury. And the same regimen, very intensive regimen. So one of the subjects actually was able to recover strength with the stimulator even turned off, which was obviously even a further step to suggest that this is helpful. Knowing that most recovery happens in the first year, and recovery after 2 years is very, very minimal, if at all. It's not clear that that happens much in terms of muscle functional recovery. So this is with no stimulation, and these little squiggly lines are surface electromyography, so it's just picking up muscle activity. And the gray shaded areas are when the subject's being told to move. So upon movement, we should see these squiggly lines go up and down in the gray shaded areas. So during no stimulation, he was able to move a little bit in the intercostal muscle, which is a rib muscle, which may be partially innervated depending on his level. And both of these subjects were thoracic levels. They might have had a little bit of that strength still in their rib muscles to be able to contract. So not sure what exactly to make of that. The authors weren't either, I don't think, based on reading their paper. Epidural stimulation on, now they're asked to move during the gray shaded areas. And they're asked to bring their toes up and their ankle up. This is the tibialis anterior, EDL, EHL. These are all muscles that help bring the toes and the ankle up. And you can see that all subjects were able to recruit those muscles more and more intensely when the epidural stimulation was turned on. And conversely, sort of interesting in getting that idea of walking, right, it's rhythmic. We got to have knee extensors turned on at a time and shut off at a time. We have to have the hamstrings turned off at a time when we're trying to step off. And we have to have them shut off. So how to do that reciprocal pattern of muscles that we need turned on and the antagonist or the opposite muscles inhibited. And what you see here is that the soleus, or the muscle that does the exact opposite, pushes the toes down, was not active during that gray period. Barely active here, turned off there. But the muscles that we want to turn on for toes up or ankles up were all active appropriately during that time. So maybe getting at the idea that perhaps we do have a little bit of information there at the base of the spinal cord that this epidural stimulation is unlocking through these other pathways, or maybe even encouraging those pathways that were injured to be able to recover some function, especially in the sensory incomplete patients. I think that's a possibility. So there are some other potential benefits there. I'm going to talk briefly about growth factor because it's 35 minutes in and I'm taking up too much time. This was a study that helps protect the spinal cord through glutamate excitatory neurotoxicity, increasing calcium in the cells. So that's a potential neuroprotective benefit of growth factors. But it also is shown to be able to improve respiratory function and decrease the amount of cord damage. There's also suggestions that it has neuroregenerative properties or help with the recovery of axons through the spinal cord injury itself. This is basically showing some similar data to what Dr. McKenna is probably going to show about stem cells. But the cells that the growth factor, when it was injected into rats, the strength of their signals with muscle activity and the speed of their signals was better. And their walking ability on the scale, the pink, was better if it was injected really early, within 90 minutes, even better than at 12 hours. And then these are the rats that didn't get the cells. So this was in a broad, big study throughout the US and other countries. We participated in this study. It was an IV drug given. So like I said, it had neuroprotective and neuroregenerative properties. It was limited to just cervical C4 through C7 complete injuries, and then later it was expanded to sensory incomplete and weak motor incomplete patients. It was placebo-controlled, so we actually don't know the two subjects that Dr. McKenna and I enrolled in this study. We don't know if they got sham treatment or they actually got the drug. That hasn't been, we haven't been unblinded yet, and the results have not been published. But over 60 subjects were enrolled, and we're all awaiting the results of that study. So with that, I'm going to turn it over to Dr. McKenna.
You guys mind if we go over it a little bit? You guys mind?
Sorry about that.
Who's on?
So I'll turn on.
All right. Can everybody hear in the back? All right. Robert?
Yeah, can you quick second fire up your presentation? And okay.
All set? Okay. All right, well, thanks everybody for coming out tonight. As Dr. Crew was mentioning, we've had the pleasure of getting to work together for, how many years is it, James? 6 years, something like that? So before my first son was born, before his daughter was born. And we've got a chance to work on a couple of the clinical trials that you got to see. I'm going to focus on a smaller subset of the topic, and Dr. Crew did a really nice job of sort of setting up the foundation for this. We're going to leave some time, hopefully, at the end for questions, and we'll just go through really two clinical trials that are both built on a concept of doing surgery, where after you have an injury at a certain point, you would have part of the bones taken off the back to be able to have access to the spinal cord, and then you would directly inject a stem cell, and there's a couple of different kinds that are in clinical trials right now, two in particular that we'll talk about today. So I'll start by giving the background of one of those clinical trials that happened here at Valley. That was a trial that was started by a group called GR1, and the scientists who worked there were very motivated by what they saw in the clinical trial early results, and actually worked very hard to get the funding to restart the company, which is now called Asterias. That trial was run at 3 sites in the United States starting in 2009. Valley, in conjunction with Stanford, was one of those sites, and we enrolled 2 of the 5 people in the country that were in that clinical trial. They were the 3rd patient and the 5th patient. We've had 5 years of follow-up for the patient who's gone through at the very, very beginning, 3 heading towards 4 years for the patient who was enrolled last. They had injuries that were in the thoracic spine, so in the chest. And often we start with clinical trials in the chest because if you had a loss at a single level in the chest, you'd lose some sensation, you might lose a little bit of your ability to cough, but it wouldn't be the sort of thing that if you lost a level, say, in your neck, where you could potentially lose your biceps or your triceps if that was something that you started with. So this was really aimed at safety, and it had some reasons to believe that this would work. On the right side, on this side, it's the right side, isn't it? Yeah. Just doing some audience participation here, Tom. That's the right side. Yeah, okay. Yeah, it's like Penn and Teller. It's a magic trick. So this is what happens to a spinal cord if you have basically a weight dropped on it, or if you take the vertebrae and you move them relative to each other. In an animal, these are very significant injuries. This is the entire cord, and this is a cavity that's forming in the center as cells die over time. And you might have a little bit of trouble seeing it, but basically there's a scar that's forming on the edge. In this stained blue is the insulation that wraps the axons. It's the part of the system that provides the electrical current, a pathway to flow through it. On the left side, the brown cells are human cells. This is a rat, so any cell that's brown means that it's a human cell that's there. These cells in the GR1 Asterias clinical trial were designed to make the blue stuff to make the myelin, to make the insulation. And the cavity is obviously a little smaller, filled with the brown cells. And you see these pathways of the blue kind of going through here, and they're even organized into paths that actually go from one side of the lesion to the other, which gives us some hope that if you think about Dr. Crew's synaptogenesis model and the model of bridging, this might be able to provide some of that bridging that could be necessary for allowing signals to get down into the spinal cord for recovery. One of the other things that was observed is that spinal cords in general will have some degree of cavitation that you can fill with these cells. So if nothing else, one of the things that's happening for these animals that are receiving stem cells is they just don't develop the kinds of cavities. The cavity size is about 1/7 the size of the animals that got the stem cells versus the ones that didn't. So that doesn't tell us a whole lot about function. It just tells us something about what the cells are doing and that they're physically there. Dr. Crew is showing a graph of recovery, and it's the same model. It's made by those folks that he was mentioning. Beatty and Brejnehan are two of the Bs in this model. Higher numbers are better. And when the FDA was looking at this data, which is the data for animals walking after they have spinal cord injuries, as Dr. Crew said it very well, walking is not done the same way in humans as it is in animals. But the thing that is good news for this study is that the blue line is if the animals receive stem cells. They get to a level of walking that the animals that didn't get stem cells will never get to. So this was evidence that the FDA used to move this clinical trial forward, implying not necessarily that humans would be able to walk, but that you might be able to establish pathways through the lesion and allow modulation of things like perhaps bowel and bladder. That was the original trial. That was aiming at thoracic, so that's for the chest. And then going forward, as the new clinical trials are going forward up into the cervical spine, into the neck, they did similar studies, and these are a little bit more complicated models of hand function, but they showed similar results that hand function was able to be improved in animals that received stem cells, and that they were still diverging in terms of what was happening. The animals that got stem cells over time were still actually continuing to improve, whereas the animals that didn't were pretty much flat. So those were positive signs that something was happening in the spinal cord. The clinical trial that we actually did at Valley had an incredible amount of logistics, and Dr. Crew and I spent a lot of time on this, and it was really, these types of trials are really labors of love. They're amazing amounts of work, but one of the things that this trial did show, these are MRIs that were done 8 times during the process, and I mean, it's a labor of love for us, but we also really got to know the patients who went through the trials and participated. And what we saw when we looked at their MRIs over time, because they actually continue to get MRIs every year for 5 years, that 4 of the 5 patients actually were showing that the stem cells were still there after several years in the clinical trial. So they were still there, present in the spinal cord over a number of years. So if they are going to work, there's evidence that we can get stem cells into the spinal cord and that they can stay. The dosing for these trials was not set up to try to prove effect. I mean, what we did was we tried to show that the cells could be put in and that they could safely be put in, and that really we were just making sure that people didn't deteriorate from having had the second surgery, or that something would grow beside cells that we would anticipate being there. So the safety part of it really was shown. To make a lot of text really simple here, after several years of follow-up for all of those patients, none of them have had progression or recovery that's beyond what we would just expect by natural history. Most people will have some recovery after a spinal cord injury. Dr. Crew is mentioning this. 20% of patients will convert from a complete A injury to a B injury. That wasn't significantly different in the study. About 60 to 70% of people will have 1 level of improvement in their muscle function. Only about 20% will have 2 levels. None of that was any better in this trial. All it showed was that the cells could be put in and that it was tolerated. So that was a background of a big clinical trial, and I'm going to move, that was the thoracic trial. I'm going to give you some historical data on another thoracic clinical trial that had a little bit different strategy. And both of these are moving forward into cervical trials. So that's kind of, we're taking the history to get to the future. Stem Cells Inc. is another company that is based in Palo Alto. Actually, I think based in Menlo Park technically, but started by a physician at Stanford. And this study, it was a little bit different in the sense that instead of using 2 million cells, they used 20 million cells, so 10 times more cells. They went to 4 spots in the spinal cord, above and below the lesion. The Geron trial was only 1 spot in the spinal cord. They had a very similar enrollment criteria. It was a slightly larger study. There were 12 patients that were between T3. There were 3 T3s. There was 1 T11. So you kind of see the numbers of people. They had A's and B's in their study. So some people had some sensation below the level of the injury. And when they looked at the recovery for the patients, they presented it in a way that some participants looked like they had some pretty interesting recovery. Whether it's really outside of the spectrum of what we'd expect, it's hard to tell. But their second out of 5 patients, they had 12 patients, 7 of them were Asia A's, and 5 were Asia B's. One of their Asia A's, people who had the most significant injuries, ended up having a sensory picture. Green is normal, yellow is impaired, but they still have sensation, and the gray is no sensation. So this is the person before they started. And then by 6 months, there were impaired sensation that were present down to about the navel, maybe a little bit lower, T11, and that stayed stable over the course of 12 months of follow-up. Now that's sensory recovery, just a light touch. It's not motor recovery. It's not them having a stronger cough or anything like that. It's not saying that they got bowel or bladder function back, but this was one of the more impressive patients that went through, one of the more impressive participants. And again, whether this is natural history, whether the person would have just recovered or not, we really can't say. I don't think anybody would attribute this to that, but it's intriguing that they did have that result in their early trial. They actually just, in this conference that Dr. Crew was mentioning that I was at in Montreal, released their results for the first year of their follow-up. 7 patients were Asia A's, 5 were Asia B's. Probably one of the biggest things that they said was that sensory recovery happened in 3 of 7 patients who were Asia A's, 4 of 5 Asia B's. And then this last piece, progression from Asia A to Asia B, 2 out of 7 patients. Not really that different from what we'd expect. We'd expect maybe 2 out of 10. They had 2 out of 7, so slightly better, but not really proving that this study knocked a ball out of the park. Again, this was not intended to be an efficacy study. It was intended to be a safety study. Now, both of these trials were in the chest. And one of the things that we know about injuries that happen in the chest is that they tend to be very high velocity injuries that cause a lot of damage to the cord. And there's an interest, and part of why the Asia B's are in some of these trials is that if you have some pathways that are still intact, there's a question about whether you might be able to get more recovery with these types of strategies. So in some ways, the less severe the injury, the hope is that you might be able to recover more by using these types of strategies. Because the injuries in the neck tend to be less traumatic, there's some concern or some possibility that even though these didn't show a dramatic recovery, that we could see more recovery as we go into the cervical spine. So now current trials, that's sort of the history kind of leading up to where we are today. There's a few resources. Has anybody been on clinicaltrials.gov, like know where to get on there to look for things? I'm going to include some references at the end, but anytime anybody's interested in looking for a clinical trial, one of the things that I would always recommend doing is trying to find something that has pizza involved in it and maybe some sodas and some opportunities for some upside. That means we must be running really late, huh?
No, they just stopped it up early.
Okay. So clinicaltrials.gov is a very useful resource. To be in it, you essentially have to be able to publish your results in the future, which means that you're really aiming to have a legitimate product down the road. You have to have put your results into this from the time that you start. So there's a nice sort of check and balance in the scientific community that if somebody is really trying to pursue legitimate science, they have a certain obligation to put their results in clinicaltrial.gov. And not only to put their results in it, but from the beginning of the time where they're starting to collect data, to have something public, to put it out, to say this is what we're going to do, this is how we're going to do it, and if our results don't turn out to be what we want them to be, there's going to be a record of it. So negative trials that don't necessarily show something, like the two trials that we showed, they didn't show grand improvement, but they're out there and everybody gets to judge them really for what they are. It's a very powerful tool if anybody's ever thinking about going into clinical trials. So the Stem Cells Inc. trial has moved into cervical, and they're aiming to get to the neck C5, which is biceps, C6, and C7. So basically getting down to wrists and elbow extension. They're starting with completes and incompletes at sensory, and they're talking about moving towards being able to have patients who have sensory and motor, so the Cs. That hasn't happened yet, but that's part of their progress on their plan to get to 50 patients. Their timeline is enrolling at 12 weeks up to a year, possibly a little bit longer than that, but that's sort of their starting point right now for the Stem Cells Inc. clinical trial. The outcomes that they're going to look for, I'm going to lump the outcomes for both of these together, but one of the things that I would say that I'm liking and appreciating about the way that groups are moving forward with their clinical trials is they're moving beyond just looking at did we get like mini levels of sensation back? Did we convert from an ASIA A to an ASIA B? I'll get into a little bit of the detail of it, but they're actually setting a bar for themselves that they want in these trials to show some decrease in the amount of attendant care that people might need or an improvement in people's function. And I'll get into that sort of down the road. The other big clinical trial, I know you won't be able to see this, is the Geron clinical trial, which is now Asterias, has moved into cervical as well. And they have a slightly different timeline. They're still the exact same area, C5 to C7. They're only starting with complete injuries, and they have a tighter time window. They're aiming for day 14 to day 30. Smaller trial, 13 patients. Both of these are actually open right now. They have opened at other sites in the United States, and I think it's reasonable to say that both of these trials are going to be available in the Bay Area in some context within the foreseeable future. More to come on that. So when I was mentioning the outcomes, Dr. Crew had touched on this, that there's a certain degree of just natural recovery. And this natural recovery at basically a year, about 70% of people with injuries will have one level of recovery. So if they had biceps, then they'll start to get wrists maybe at a year. And then very few people, 26, 25% of people would go to the point where they would have triceps if they started just with biceps. Now, why that's important is if you think about the burden of care for patients, I think Carol Adler might have had something to do with setting this chart up at some point in the past. Carol Adler is one of our therapists who worked at Valley for 5 or 6 years and retired 3 years ago. Is that there's a certain amount of attendant care that's required predicted to be required at C3, C4, 5, 6, 7. So if you think about the bar that these clinical trials are setting for themselves now, what they'd like to be able to do is like to be able to take someone who's a C4, for example, and move them into the C6 category. You know, all of these categories would be total assist for doing these activities of daily living. And then if you could get 2 levels of improvement, you might need a little bit of help for some pieces of it, and other pieces you'd be completely independent. If you started at C5 and went to C7, you could get attendant care down to a very dramatically reduced level. You know, whether they're going to be able to achieve this or not is, you know, still completely up for debate and speculation. We don't really have evidence in humans that any of these treatments have ever been able to reach this bar, but I do think that it is valuable for us to know what we're aiming for and to be able to say if we're achieving this, then the scientific and advocacy patient group communities have come together to set these sort of standards up, and I think that they've set up some fairly reasonable standards for what we would want if we're going to move these products from trial status into clinical practice. So with that, I think I'll just leave the references. Clinicaltrials.gov, you can find by just going to this website. It's one word, no hyphens or anything in it. This other page that we have up here, the scope-sci.org, is a very useful page that keeps track of right now about 30 clinical trials that are ongoing, that are registered in this website, the clinicaltrials.gov website. It's maintained by an advocate physician at Craig Hospital, Dan Lammerts, who spends a lot of time keeping not just the list of trials open or available, but also tells a little bit about what the inclusion criteria are and how they're sort of changing over time, whether they're open or closed.
Dr. McKenna, can you repeat those slides? I don't have the slide.
Oh, yeah, sorry about that. So it's clinicaltrials.gov as one word, and the other one is www.scope-sci.org, and SCOPE stands for the Spinal Cord Outcomes Partnership Endeavor, is where the word SCOPE came from.
Oh, there's no last slide. Oh, it's your last slide. I just put it. I said it.
Yeah. Yeah, so I think that actually is my last slide, and I think with that we'll open up pizza boxes and questions, and yeah.
What's your stem cell therapy? How is immune rejection?
Yeah, no, it's a really good question. So the question was, for stem cell therapy, how do you manage immune rejection? So both of these clinical trials start with a cell that is not your own. It comes from another person in some capacity, and then it's injected into your spinal cord. Both clinical trials have some degree of immunosuppression for about 60 days, for a period of time, and then after that, you're taken off of immunosuppression. And part of the reason I was showing that slide of the MRIs for patients who were years out is you could imagine a couple things would happen, that potentially the immune system would recognize that there are cells that are not from your body, and they would go in and attack them. The MRI evidence is that that doesn't happen. And another thing that we did that the FDA really wanted to find out is there was a period from day 45 to 60 when immunosuppression was taken from a level which is basically if someone had a kidney transplant and they were just walking around in the community, a lot of people would be on a low dose of the same medication. As we took that down from that level at day 45 to day 60 when it was off, we would do ASIA exams. We would do the neurological exam on a every 3-day basis to make sure that something wasn't changing. And we didn't see any evidence that people had regained function and then lost it because the cells were dying during that period, or that patients had any deterioration, say, inflammation that might have come up as the body was reacting to cells that were in that area. So they do survive on an ongoing basis is one of the things that these early trials showed. And there's a couple reasons to believe why that would happen. The neurological system is a privileged compartment in a sense, in a way that the body doesn't get in and try to attack things in it, like stem cells. That can be a bad problem if there's a bacteria in the neurological system because the immune system doesn't naturally get into the neurological space very well. And also these cells are very immature, and immature cells don't present the same they don't have the same machinery on their surface that allows the immune system to recognize them. So they tend to be, the cells tend to be not very likely to be rejected, and the immune system isn't a very active place for immune rejection. So yeah, no, that's a really good question. So the question was, do the cells differentiate? And there's something sort of built into that that's sort of a subtle question. We talk about giving people stem cells. And that's actually a little bit of a misnomer. What we're actually doing, say, for example, in the Asterias trial, is we're taking stem cells and we're moving them down a specific pathway to a place where they're going to make a specific tissue. They're going to make, in the stem cell case for Asterias, they're going to make myelin. So they're like a cell called an oligodendrocyte precursor, which just means they're defined to be in a place where they're going to make myelin, and they're going to basically do one or two very specific things. In the process of doing that, they also secrete growth factors that are sort of relevant to what they are at that point. But we're not actually injecting pure stem cells, because one of the risks at that point would be that they could become other types of tissues. Tissues, I could keep going on that for a while, but anyway, they're basically targeted for a certain type of outcome.
All these trials you're talking about, they're normally to test efficacy or safety, and one was 2 million cells, the other one was 20 million. How many cells would you say would be for actual healing? How many injections? How many cells would you inject?
Yeah. So the question was, it seems like there are different things that the trials are trying to do. Sometimes they're trying to test safety, and sometimes they're trying to test effect. And then how many cells actually would be needed to get effect. So those trials that we mentioned that happened in the past were specifically designed to have the lowest possibility of an adverse outcome. And the way that they had made their decision about how many cells to give is they took an animal model, like a rat model, and they saw how many cells were effective in a rat. And as Dr. Crew was mentioning, there's a known size of the spinal cord in a rat. So if you scale the rat spinal cord up to a human spinal cord, for the first clinical trial, you get a dose somewhere in the ballpark of 20 million would be considered potentially the effective dose, so 10 times what was given in the first trial. So we're aiming in the next phase to get from just doing safety to a place where we would be really giving our best guess from our estimates in animals, translating that to humans.
Wasn't one of the trials with 20 million cells that you did?
Yeah, so they did. So I haven't done that trial. So the trial that used 20 million cells was the Stem Cells Inc. trial. And they had a different model that I don't actually know as much of their sort of background detail on how many cells they felt that they needed. But the general principle is that we generally wouldn't go in and use the most likely to be effective cell dose at the beginning. We're going to be moving more and more towards that as time goes on. The Stem Cell Inc. team tends to be a little less, they tend to tell the public less about what their cell numbers are, so I've never seen them published, so I can't say.
We have a question here. Online, just stop real quick. Are there any current or upcoming clinical trials for a patient with a C4, C5 complete spinal cord injury? If so, what medical hospitals, universities are taking patients?
Yeah, so the question is basically for higher level injuries, if you had a C4 and potentially an incomplete injury, what trials would you be eligible for? Another factor that I would put into that is what's the time since injury, right? So if you think about what kind of the different elements are that are going into the decisions about who's eligible for a trial, they're at least threefold. One is where in the spinal cord, what has happened to the spinal cord, A, B, C, and how long out. Some trials are 12 hours, some trials are up to a year. Yeah, so, in terms of which trials are available, what I would recommend is the best place to find that is to go to the www.scope-sci.org website, and they have a list of 30 trials, and they would tell you exactly what their enrollment criteria are. Once you find out what the enrollment criteria are, one of the ways to find the sites that do these is then to take that and go to clinicaltrials.gov, and you can find the contact information for sponsors at that point. Let me go back to that one.
Yeah.
Just real quick, Dr. McKenna. There's quite a few of us in the room that have a number of years under our belt in terms of our spinal cord injuries. It appears, at least from what I can tell, that some of the therapies Dr. Crew discussed and some of the studies that are really for newly injured, more recently injured patients. Is that? What's the whole goal of 10, 15, 20 years? Yeah,
I think there's a variety of things that are happening. If you look at some of the trials like the stimulator, that actually is aiming a little bit on the longer end. Some of the trials are aiming very, very much on the short end, kind of aiming for trying to understand some things about biology. One thing that I think that part of why I think a group like this is very important, not just for us to come and present to, but also to be advocates for, is that some of the strongest voices to try to move that needle to say, where should the research dollars be put, and what is going to be studied come from the voice of the people, and saying, you know, this is something that, you know, we find unacceptable. I think, you know, many of you have met Roman Reed. I mean, I think he has an ongoing sort of thought process about trying to have treatments available for a broad variety of conditions. And there are ways that science could potentially act in the longer course of injury. I mean, there's thoughts about could we break down the scars? Could we have research that goes into the spinal cord and tries to identify, you know, what would be stopping axons from going from one side of an injury to another side of an injury? Could we take that out with, say, an enzyme that would break down scars? And then could we replace tissue that's been lost with matrices, using therapies where we actually implant cells into tissues that allow these to be put in even if the injuries aren't fresh? We didn't talk a whole lot about that today, but those are, you know, those are things that are definitely under development at this time that may not have as much of a focus just on the acute side.
Yeah, I had a question about a procedure that was published recently and sort of in the research media has heard about it. It was a technique that developed in London. It's transplantation of some nose above and below the injury site. And I guess this was done by some Polish surgeon that was working on a 38-year-old period. And you probably have some.
Yeah, I thought about it. I obviously went way over my time, so I'm glad I didn't include that. But yeah, so that is an olfactory and sheathing cell study, and those are actually potential cells that have the capability of neuroregeneration. So there's actually research going back at least into the 90s showing that this is a possible strategy to improve neurological recovery. And I believe in that study there's different bridges, so to try to put those cells around or in the spinal cord, or to put them at least in the central nervous system so that they may bridge the site of the spinal cord injury. So putting the cells above and below the lesion itself. And then I think they used a peripheral nerve that they harvested and put in with those cells to try to allow connections to be made sort of around, sort of a bridge across, if you will, the injury itself. So yeah, I'm aware of that. I think Dr. McKenna is aware of it too. That was a pretty limited study, but that has gained enough notoriety. When I looked at the SCOPE website, I don't see that they're in a broad, at least an open, well-established clinical trial yet, but that is another theory that's sort of like stem cells, but a little different in how it would work in the nervous system.
Yeah, I saw some videos of even
right.
using that same technique.
Right. And I think some of the questions are getting at, you know, are these just for sort of acute injuries? I put up the timeline with the epidural stimulation study. Those patients are well over 2 years out from injury. One of them was over 4 years out and is showing signs of ability to move muscles that they haven't been able to move for more than 4 years. If you look at this, going back to kind of where we started tonight, there isn't one thing out there that's going to fix a spinal cord injury other than to go back in time, right? So none of these strategies that we've talked about really hold probably the potential to cure neurologic deficits after spinal cord injury. But if you think about the different areas that these strategies can help, maybe cooling and a lower dose of steroids early on, maybe Riluzole, all of those being neuroprotective strategies that are studied but maybe not have enough evidence behind them yet, or we haven't hit the right doses to get them in broad use. So that would be an early strategy, a few early strategies to decrease the amount of neurologic damage, right? And then moving into something like growth factors that can sort of decrease this excitotoxicity leading to increased calcium and eventually leading down to cellular death. Then moving on to stem cells, somewhere before, sometime after the initial inflammation, so the cells aren't recognized and killed off by our immune system, but before the scar is formed, something that Dr. McKenna talks a lot about and is sort of talked a lot about and by those who do the studies. That's why that timeline is picked, that 14 to 30 days, because in the rats, if you put the stem cells in too early, they don't make it. If you put them in too late, there isn't as much recovery. So there's a window for all these things, and if we can get to a place where they're more there's more evidence behind each of them to do it's really its own thing rather than to be some hope of miraculously curing spinal cord injury, but all taken together could lead to a dramatic improvement in function. And I think that's really what the research is more pointing towards now. And any of these studies you read, if you read in the discussion, this idea is talked about. This is one of many potential strategies that probably need to be taken together to really affect a major change. So, if you want to.
Yeah, good.
Another, oh yeah.
Yeah, I have a question just talking about timing. With the stem cell implantation, what was the average time from the injury to rejection for patients or study that gave us some sense from there and we wasn't acceptable time?
Yeah, so so the question basically was for the stem cell trials, what was sort of the range of times when patients enrolled. They were by design very different in the two trials that I mentioned. In the Geron clinical trial, they were actually between 7, so this is going to be the new time window, which is a little bit long. You can go back to Geron if you want for a sec. Sorry, Asterias. Geron and Asterias are basically the same group. They've moved the time window from 7 days out to 14 to 30 days. So there was an earlier time window in the original clinical trial, which seems like it was actually very hard to get patients into that trial. This, in practice, is probably more reasonable to actually do on a broader basis. The other clinical trial that we mentioned was the Stem Cell Zinc clinical trial, and they're aiming to get past 3 months. Up to a year and maybe even possibly going towards 2 years. So they're looking at a potentially longer time window. In terms of which one is going to be more effective, it's hard to say at this point. There's sort of reasons in animals to think that there's a certain time window that might work the best, but there's been a lot of concern that that time window in a rat isn't the time window for a human. The size of the cord is different, the biology is different. Some things that happen maybe right at the very, very beginning with calcium and things like that are the same, but some of the things that we would anticipate would happen later around this 30-day time period are probably very different for humans versus rodents. So we really won't know until those trials happen in humans. Yeah.
You have a question here.
Have they tried any of the trials in like monkeys or animals that are more similar to humans?
Yeah.
Yeah,
there's a big debate in the whole community about how best to do these trials. By and large, there haven't been a lot of trials in primates because primates they're very hard to take care of in these types of clinical trials. Once they get these types of injuries, they have behaviors where they're very hard to take care of. And even there's a more subtle question even sort of behind that, which is, are the animal models that are being used even in rodents really similar to what's happening in humans? Humans tend to have accidents that are not necessarily as precise as what's happening in the rodents. So, there's a lot of reason to think that the animal models might tell us about safety, but they're probably not really going to get us the answer about efficacy. If a rodent gets a tumor, we really need to be making sure we're not doing that. If a rodent has a deterioration in their neurologic function, we really need to not be doing that. But if they don't demonstrate the same type of recovery with the models that we're using, we may not really even know until we get to humans. So there's a middle ground where people have tried to do some of these studies in larger animals, like in pigs. And usually what those studies are aiming for is more to figure out volumes and what's the right volume, sort of similar to what the question was asked before. What volume can you inject into a cord without causing additional damage? So it's sort of a complicated, part of it is ethics, part of it is animal rights, and part of it is just what you can really do to take care of an animal after they have a spinal cord injury. It's very hard, as we all know, it's very hard to take care of a human after a spinal cord injury. And some of the things that animals have as behaviors make it really just unethical to do some of these trials, even for some of the animal models that we might think would make a lot of sense.
I have a question here. Are there any studies or any interest in studies involving patients with incomplete cervical SCI, HSC or D, under 10 years past initial injury or after 2 to 3 years post-injury. Is there any potential for recovery?
Well, you know, I think that Dr. Crew, and actually the question that came up before about this bridging nerve strategy, I haven't seen clinical trials that are really moving to get that strategy into. So basically the question is, again, it's sort of a specific category of slightly longer term and slightly incomplete injuries. I mean, that's sort of a broad category. I think that the idea of bridging nerves is actually a very, very interesting idea. If you think about the way that most spinal cord injuries happen, they tend to be very focal. The bones in like 1 or 2 segments tend to move relative to each other, and you end up with a piece of the cord that's very damaged, and then the cord below it, you know, Dr. Crew did a really nice job of talking sort of about the intelligence of the cord. That intelligence at the bottom of the cord is still there. The intelligence of the part of the cord that wasn't damaged is still there. If we took nerves and had a way to actually bridge them almost like a cable across the injury, that could happen at any point because the cord itself is still alive. It's still completely intelligent in its ordinary way except for that one region that's damaged. To get to the specific answer to that question, I haven't seen specific clinical trials that are using that strategy, but I think that would be the strategy that would work in that case. And I know that people are very interested in trying to bring those strategies forward. They're not going to be, you know, this is another place where advocacy I think actually really matters. They're not going to be a single drug that some specific company is going to get a huge profit from. They're not going to be a stem cell, a biological that there's a way to patent. I think a lot of those solutions are actually going to be solutions that are going to be built around surgical techniques, using ideas that maybe are partially patentable, maybe they aren't, but some of the things that are going to work, I think, are going to have to come from research that's really driven by community interest and coming up with solutions to problems that aren't immediate and don't have immediate profits. And that's, you know, that's a very hard thing sometimes in the world that we live in now to make sure that those types of treatments get brought forward.
We have one question here. Does I'm a nurse and also have an L1 injury 1 year out, and I found it difficult to get evidence-based information regarding the best actions to take for therapists to participate in non-medication to maximize my potential for recovery. Can you speak to why this is so difficult to stay informed about and how one would determine how to maximize recovery potential?
So, shall we repeat the question?
It's just for Janet. Listening in, so you can.
Is she the only one left? Oh.
No, there's still a lot of people left. So you can just kind of summarize.
So I think the question is, recent injury, you said how long ago, a year?
L1, 1 year out.
L1 injury, 1 year out, having a hard time getting reliable information about spinal cord injury and also about potential studies that she might be eligible for? Is that sort of?
Yeah, maybe being started to.
And maintaining health?
Sounds like she's wondering about how to maximize PT regimen, right?
Yeah, okay, good. So, you know, I think being involved in a group like this is a good first step. Certainly, spinal cord injury is not a very common condition. There's only like 12,000 new injuries in the whole country every year. So that means the healthcare system oftentimes isn't very comfortable dealing with spinal cord injury, and many places don't have physicians, nurses, therapists, allied health personnel that are terribly knowledgeable in spinal cord injury. So depending on where someone goes, they may have a very different experience than if they go to a center that knows and has a lot of skills and is very focused on the management of spinal cord injury. So I think that's one thing. We can't go back in time, but trying to get linked up with a center, maybe get linked up with our outpatient programs to try to get more information, to try to have a team that works with you that can provide education and try to come up with a long-term plan for your health and well-being. So I would say that's probably the best thing. There are adaptive exercise programs in the area. Through every community college, there's adaptive exercise programs that can focus on health and well-being, and our therapists could work with you in developing a regimen that you could carry forward. There's also somewhat controversial, but also very useful programs aimed at functional recovery, including SCI Fit, who I believe presented here, and Project Walk, that some of what they do are very well evidenced through functional electrical stimulation. However, having education and asking questions and having the right hopes going to those programs is a must. So I don't know if that answers it, but yeah.
What does a person need to do to be in the best position as a clinical trial in the future? Will be in the best possible position to take advantage of that.
So that's a really good question. So maybe I didn't quite hear it, but the question, the clarification is, what can a person do to keep themselves in the best shape to be ready when there are treatments that they're eligible for that could drastically improve their function? And I think that is maintaining health. I mean, the simple answer is maintaining health, maintaining well-being, not getting out of shape, not gaining weight, not getting some of the secondary problems that come after spinal cord injury, including endocrinologic problems like high blood glucose levels, borderline diabetes, higher risk for heart disease. So trying to stay on top of one's health is challenging in the able-bodied population, and I know it's much tougher after having something like a spinal cord injury, but that is the bottom line. Trying to not have joint contractures, trying to make sure that the muscles you do have maintain a relatively good bulk. I think that some of you were here when Robin Gibbons talked about functional electrical stimulation in rowing devices. That's a possibility in cycling devices, and for those of you that have spinal connections that are still intact and that don't have lower motor neuron injuries that are pure lower motor neuron, that is a way to stimulate muscles, to maintain bulk, to maintain health, and also a way to trigger improved cardiac, metabolic, and pulmonary endpoints over time. So I think that is one means to do it, but there's other ways to stay healthy, and I think a lot of what the topics you guys cover here, nutrition, FES, exercise, adaptive, adaptive exercise options in the community, I think a lot of that, if you take it all together, that is a way to stay healthy and be ready when some of these things are more available. And I think, getting back to Marv's question earlier, Epidural, that would be done much down the road. So if it gets to a point, if it's working in someone who's 3-4 years out, there's no reason to think it wouldn't work in somebody who's 10, 15, or 20 years out because of the way that we think, at least, that it works.
If there might be more questions, I think we can wrap it up.